Have you ever watched a child struggle to catch their breath and felt the wave of panic rise in your chest? Whether it's asthma, a stubborn cough that won't go away, or something more serious, breathing issues in kids can be terrifying for parents. I'm Dr. Jay Rutland, and I'm a parent as well. And today on the Health Exchange, we're diving into pediatric lung health with Dr. Sande Okelo, Division Chief, UCLA Pediatric Pulmonology, and expert in asthma, and Dr. Lori Livingston, attending pediatrician at Miller Children's Hospital in Long Beach, and assistant clinical professor at UCI. We'll break down what every patient, caregiver, and clinician should know and how we can all help kids breathe a little easier. Let's get to it. Dr. Okelo, Dr. Livingston, thank you so much for coming today. Dr. Livingston, let's start with you. Why don't you tell us about yourself and where you are, how you got here?
I am a general pediatrician for the last 18 years. I work right here in Long Beach. I have a private practice called Pediatric Medical Center, and I ended up in Long Beach because of my pediatric training and residency through UCI and Miller Children's Hospital, and I fell in love with Long Beach and wanted to stay. As far as how I ended up as a pediatrician, I have always loved kids. I started my own babysitting business at 11 and loved science and anatomy and physiology, of course. And I went straight through. I was somebody who knew what I wanted. But I think kids have always called to me because they bring joy to our work every day. They make us laugh. And it feels like I can make a big difference. I feel like I'm intervening before huge problems happen. So I love being a pediatrician for that reason, and educating families, which I know is what you do, is a huge part of what we do.
That's amazing.
Yeah.
Dr. Okelo, how about you?
Yeah, my journey, I've been a practicing pediatric pulmonologist for about 20 years. I've been at UCLA as the division chief for about 13. I came to build that division and build an asthma center. And it's one of my passions, having had asthma as a child. I'm sure we'll get into that a little bit later. Did undergrad at Stanford, med school at Case Western, residency at Oakland Children's, and then fellowship at Johns Hopkins before moving to Los Angeles.
Wow. And for those of you that don't know, the person that I call every time I have a pediatric issue in my clinic, I just call him on the phone. And I'm like, yo, Sande, like, what do I do? These parents are...
Can I have your phone number?
Of course, of course.
That's exactly how the circle. That's why you're here,
Of
to get
course.
Sande's number.
Totally.
Again, I know stories that I've had in my life throughout my career, I guess, that led me to loving pediatrics. But what about you guys?
I think the babies, for me, are what draws you in. When I was a med student doing rotations, I, for example, on OB-GYN, was really interested in what was happening, but I would always gravitate to what's happening with the baby after they're born, even though I was also interested in women's health and all of the other medical issues in every specialty that we train in.
Yeah.
I always gravitated back to the kids, and babies are just so innocent and moldable, and you feel like you can help parents navigate that exhausting and challenging time and hopefully not mess up their kids as much as the previous generation. We're all messed up a little bit, but it's a privilege.
Sande, is there a story that sticks in your mind?
I think a couple. As I mentioned earlier, I had asthma as a child, had a few ER visits, did immunotherapy. So I felt growing up I had kind of a unique experience or interaction with the healthcare system that I think probably could have been better. I'd say more so in hindsight, but a realization at the time. Second, I'd say going through med school rotations, you do your rounds, OB-GYN, internal medicine, and so forth. There were two rotations that I really did like. One was surgery, and the other was pediatrics. And for pediatrics, it's just more family oriented or family centered. And that was really appealing to me, just having that relationship, not only with the patient, but with the parents as well.
For me, I remember, again, everybody knows I trained at University of Iowa, and at Iowa, you got to make a decision where you could do some of your rotations in Des Moines. So I was doing the rotation, and it was an inpatient. We were on inpatient service, and there was this kid who he was probably about 4 or 5 years old.
Mm.
He wouldn't let anybody examine him and look at his wound that he had in his belly. And we're just rounding. I'm with the attending, and I remember going into the room, and I was just looking around his room, right? He's got all these toys, all this stuff, and there was this, like, Optimus Prime mask, the Transformer,
Yeah, yeah,
and I was like, "Huh." And so I grabbed the mask, and I put this mask on,
yeah,
and then I was like, "I'm Optimus Prime. I need to listen to your heart and your lungs and look at your belly." And he was
yeah.
like, "Yeah," right? Just opened right up. And I remember doing that, and I was just like, "Oh man, pediatrics is like amazing. Like, this is great. Like, you get to play with toys and I
Yeah,
play with masks. Like, I would love to do that every
totally.
single day of my life." Right. But then I remember as I went through the rotation, the ignorance of kids was beautiful for me because most of them didn't realize how sick they were,
Sure.
but you got to take care of them, and you could make them smile, laugh,
Right.
whatever. But the people that you spent a lot of time with were their parents,
Sure.
and we're parents, right? You
Yeah,
get so worried
Mhm.
about your kids all the time,
totally.
and just dealing with the child was great, but for me, the parent stress was like it was hard to deal with at times.
It's our biggest challenge as general pediatricians is taking care of parents too. They're our patients as well,
Yeah.
not just the kids, and they're the people that we are educating the most. So that requires time and patience, and I think it's rewarding when you are able to connect with parents and they trust you, and even though they're worried, they are able to set that aside a little bit because they know that you have their best interest and their child's best interest. I think in the hospital setting, that's a little more challenging because they're much more sick and they don't know you as well. But as an outpatient pediatrician, we have really strong relationships. So over time, even though parents are very worried, they let us guide them.
Yeah, it's a great point. Every facet of medicine has its challenge. A couple things. I think first is a lot of pediatricians will tell you they're better pediatricians after they have kids. And I think it's that empathy and relatability to the emotional side of being a parent that helps make myself, probably both of us, I think, better physicians as far as relating to, like I said, the emotional side. I think as physicians, we're trained to spew facts, but facts don't always resonate with patients. There's a human side, an emotional side, a psychological side that we need to learn to tap into. I think that's helped me immensely, and sharing that. It's relatability in the exam room, if you will, that I think helps foster that patient physician relationship.
Yeah, it seems, we're talking about kids. One of the things that's different between taking care of adults, taking care of kids, is you've got organ development as the kids get older, and specifically even lung development. How do you, Sonny, think about lung development and these kids that you're being called to see for obviously a lung reason? Like, how do you think about that in your mind? So if somebody's calling you, you're like, how old is the child? Like, what exactly is the problem? How does that play out?
First is as a pediatrician, our overarching goal is to, as best as possible, assure the healthy, development of these kids so that if and when they do see adult physicians, they're in the best shape possible. And so I think that means having, I would say, a more cautious approach about to all the possibilities of what may be injuring those lungs. So that's always at the forefront. I see children anywhere from soon after birth to 21 years of age, but it's those youngest children whose lungs still are developing that will focus kind of doing the most intensive evaluations just to be sure that nothing is impeding that normal lung development process.
When you're seeing patients, or when you did see patients in the hospital, newborns,
Mhm.
is that kind of one of the organs at the forefront? Like if the kid was born at 32 weeks or 31 weeks, is that what you're thinking about kind of right away?
Absolutely. Cardiac and lung development. Is this child going to be able to make it if they come out early? or if they have some residual fluid in their lungs, all of the common things. As general pediatricians, we think about the horses, not the zebras, we say in medicine, right? What are the common things? And 99% of the time, that's what it's going to be. So if we see a child who is working hard to breathe, there's a lot of things to think about. It's usually pretty straightforward, but there are those rare cases where we need help from the specialists. And that's when we ask them to come in when our usual investigations or treatments are not working the way we expect.
One of the things I thought about and thinking about developing what we're going to talk about today is bronchopulmonary dysplasia, right? And so we all know, and for you guys out there, when you are conceived and now you're a dividing cell within the inside of your mother, organs develop kind of at different rates. The lung starts developing in about 3 weeks, 3 to 6 weeks, and the cells start to divide, and then they start to separate out the different aspects of the lung and architecture and all of that. But that process of the lung development takes place over the course from that 3 weeks to like 36, 37 weeks. I myself was like 2-3 months premature. And so when I'm reading about bronchopulmonary dysplasia and the development of the lung, I'm like, man, I got that shit. Like, what's wrong with me? Like, maybe that's why I can't breathe and I'm running fast sometimes. But it seems to me that like there's a lot of kids that are born premature these days. BPD has got to be common. And I'm sitting here wondering, like, it's fascinating to me that there's a lot of individuals that are completely fine, but it seems like every premature kid is going to have some element of BPD. Is that the case?
Children born younger and younger are surviving that, but their risk for the BPD does increase the younger they are. Many children do well, but we know in general across the board they're at higher risk for developing asthma. So they may leave the NICU or the nursery doing okay, and then they may show up in my office at 3-4 years of age because of exercise-induced, shortness of breath or chest pain or that type of thing, which ultimately will end up being asthma.
And are you screening for that in your office? Do you do, again, I don't know, do pediatricians do spirometry or lung volumes every so often? How does that work?
Some do.
Yeah.
My personal practice does not have pulmonary function testing, spirometry, even using the old-fashioned, forced FEV1, forced volume to try to assess asthma. We don't really do that. We go more based on physical exam findings, pulse oximetry, see how they're oxygenating. But, speaking to those babies with lung injury or immature lungs, I think it's amazing how things continue to develop and heal when kids are young. Just like we talk about other injuries that kids have, whether it's a laceration or a brain injury, they actually, depending on the severity of the injury, so many of them do remarkably and surprisingly well and recover without anybody knowing that there was that serious injury. And I think the lungs are similar. Like they can withstand pretty significant injury, whether it's infection or pneumothorax or premature birth without enough surfactant. And they do incredibly well with the medicines and over time. So we see this like healing of the lungs, which they probably don't have normal lungs. Maybe you don't have completely normal lungs.
Yeah, probably not.
But on the surface, you're mostly not going to have problems unless you're really pushing yourself to the extremes, maybe, is how it usually goes as an outpatient. There are those kids that have very severe chronic lung disease because of their initial injuries during prematurity or whatever their underlying problem was.
One of the things I noticed, and again, South Orange County, not Los Angeles County where they practice, but in South Orange County, the most common condition in a kid is asthma, I guess, right? It's one of the most common chronic inflammatory conditions. In South Orange County, pediatric asthma is just drastically undertreated. And when you look at the numbers across the United States, 44% of kids with asthma are undertreated, which is something you and I, we all talk about, a lot. When you look at the development of the lungs, the pediatric lung, the bronchiole, is already more narrow than an adult bronchial, which lends itself to a higher rate of airway obstruction, especially when it's inflamed. Why do you guys think that pediatric asthma is undertreated?
I personally, in my practice, both inpatient in the hospital and outpatient in my office, think that parents have a really hard time with giving their child medication daily for an unknown, perhaps forever period of time. It takes a lot of time sitting with them and explaining the why behind these things we recommend so that they understand that this is preventative, so their child doesn't end up in the hospital again or can play the sport that they want without having to stop or slow down. And that just takes more time than most doctors have. And that's unfortunately the system that we're in. We have to fit in a lot in a short period of time. It's hard to know if a child has asthma when they're little. We see so much wheezing and trouble breathing for other reasons, and we try not to label them with a chronic illness if we're not sure. So it takes some repetition of wheezing and trouble breathing over time before we feel like we can say, okay, yes, this is asthma. Because there's no one diagnostic test. If I had PFTs, pulmonary function testing, that would help. Yes.
It's definitely very hard because, again, like I said, the whole reason I started seeing peds again was just because of that. And, now seeing more and more 5, 6, 7-year-olds with asthma, I do spend a significant amount of time talking to the parents. And I'm like, listen, this is what's happening. This is what's going on in the airway. This is the inflammation that's taking place. This is why your child needs to be on persistent therapy. It's an education thing, I think. I think it's a disease state awareness type of thing.
I would agree. I think if we dive deeper into the process of training, the opportunity and emphasis, for example, is not on diagnosis of asthma, not really. If you were to look at, for example, how pediatricians are trained, who trains them, what the training process is like, there's really very little rigorous education around diagnostic criteria for asthma, for example. We could go survey 100 residents right now. Who do you think could list the NIH diagnostic criteria right now?
Please don't ask me.
So a lot of physician training, many people don't know this, during what's known as our residency is about providing a service to a given hospital. That service to the hospital doesn't always align with the education that would be optimal, for example, for accurately diagnosing asthma in a practice.
All the asthma stuff that I know, the immunology, all the things that I teach, I didn't learn any of that in residency. I didn't learn really any of that in fellowship, to be honest. Sorry, KU. But I taught it to myself just because I have a huge interest in immunology. But when I think about it, if you go even to the hospital, where do most of the asthma exacerbations go? They go to the fast track. And who's in the fast track? The NPs and the PAs are in the fast track, right? It's not really the residents or the fellows because they think, oh, it's so common. You're supposed to know this. But I think you're right. I think a lot of kids don't. And so when I take PAs and NP students in my clinical practice and med students that want to rotate. And the first thing I teach them is I teach them about asthma, obviously. And they don't know that much. I'm not criticizing their institutions. I'm criticizing their own lack of curiosity in a very common illness that affects a lot of people. So yeah, I agree.
Your point is great that you have to continue to ask yourself those questions and take the initiative to learn on your own after you are in practice, because there's not enough time in residency, and it depends on who your role models are. If they explained things to patients well and you learned from listening to them, and you have to look it up yourself and learn how to explain things in an effective way to families so that they get it and they buy in. There's not enough time in our training. I think I had exceptional mentors and role models, and it still has been 18 years of practicing how to say things so that parents get it. When you have a cough every night, that's not normal. And we need to figure that out and fix it so that your child can sleep well and be athletic and be healthy. But parents let things go. They also save up all their questions, understandably, for their 1 year physical. And I have a 15-minute appointment to answer all their questions. And asthma's in there, or just cough and allergies and eczema that always go together. And I have to address all of those things somehow while also doing all the other preventative stuff at a well child check. So it's basically impossible, but we try to make it happen and we ask them to come back. But people are busy and they want to live their lives. And so, unless their kid literally can't breathe, they don't bring them to the doctor, is the other culture that we live in. Like, just don't go to the doctor until there's a serious problem.
Yeah, there's something, you guys, just for parents to know, there's something called the atopic march, which really starts with atopic dermatitis or eczema, just a rash. Then it goes into food allergy. Then it goes into allergic rhinitis or hay fever. And then it goes to asthma. So if you start to see these things in your child, if you see a rash in your child and you see the eczema, you've been diagnosed with eczema, you really got to start thinking, is my child going to have allergies? Is my child going to have, allergic rhinitis, and which is sinus congestion and inflammation? Are they going to have asthma? Because these things go together. And so my question for you, Sunday, is if there are three things that you want parents to know or when to think that your child may have a diagnosis of asthma, what are those three things?
I think first and foremost, if you feel that your child's symptoms are disruptive to your life, disruptive to getting regular sleep at night, disruptive to being able to attend school consistently, disruptive to playing in sports. Just if these symptoms are getting in the way of those regular day-to-day activities, then I think that's an opportunity to really sit back and think, oh, wow, this is a little bit different than the typical child. If your gut sense is that just in general, regardless of whether those are happening or not, that you're not satisfied with the answer that you're getting, whether it's they'll outgrow it, whatever it is, or, just if you're not offered an actual diagnosis to explain, to make you comfortable and assured in not only what's happening now, but what the future holds. And then third is, I think, paying attention to some of the signs that you mentioned. What about the family? Are there other people in the family with asthma or allergies or eczema? Is this something that is a reasonable consideration? How about your own past?
Yeah, it's funny because what they do really well, at least I think, in pediatrics is like ear infection. If a kid has an ear infection, like once or twice, it's like, boom, ENT referral, and they get eustachian tubes or whatever. Like, they do a great job with that. But for the asthma thing, it's just like, it really is crazy. And the reason I care so much about it is because at least in Southern California, you've got black neighborhoods, you've got white neighborhoods, you've got, neighborhoods where people live in poverty. And it turns out that in those neighborhoods, those kids have higher rates of asthma, right? Because diesel trucks can drive through those neighborhoods because those neighborhoods are right next to freeways.
Mm.
And so, when I get a kid that looks like me that's in my clinic, like I pay special close attention to that because I know that that person really needs to understand, or the parents really need to understand, the risk factors that are contributing to their airway inflammation, right? Because your lung is a tremendous responsibility, breathing in all these molecules and having to sift and deal with it and not cause inflammation. But your airway epithelial cells can respond to whatever they want. And they'll just say, you know what? I'm going to respond to this. And boom, you get this inflammation and you have this wheezing and coughing.
When I was a resident, I lived in downtown Long Beach, and I remember the layer of black dirt on my patio, which was from the port and the busy streets, I assumed. But I don't have asthma and allergies, but knowing as a pediatrician in training, this is disgusting, and this in your airways cannot be good for anyone, let alone asthma. And then the families that have 10 people living in the household plus animals and smoking. And, these are common things that we see in kids that are hospitalized with asthma. And those feel like impossible things to change in the way that families have to live to survive.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. Today's question: what's the difference between asthma and other chronic lung conditions in kids? Do they use the same medications? Well, that's a very good question. When you think about asthma, which is allergic inflammation of the pipes carrying air to the lung, the medications that we use include nebulizers, inhaled corticosteroids, long-acting beta agonists, long-acting muscarinic antagonists. These are typically inhalers that are going to affect inflammation of the pipes. We want to calm down that inflammation, and we want to allow that pipe to be as wide as possible, which is what the beta agonist actually does. If you think of another chronic lung condition like, let's say, bronchopulmonary dysplasia, this is a developmental problem. The way the lung actually develops in children is in different stages. And so as certain things happen, certain things are going to look a certain way. In BPD, bronchopulmonary dysplasia, these things may look a little bit different, and it could affect the way that your body gets oxygen. So the therapy for that may be oxygen, which isn't quite a therapy in asthma. That's this week's Buzz. We'll see you next time. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. Sometimes you can't change the patient's environment, where they live, what drives down the street. But the one thing that you can change is the way that you manage them and the way that you address the diagnosis that they likely have. And so for me, like in those areas, or when I get those patients, I am probably more aggressive because I know where they live and I get the environment that impacts them significantly. And so I really am like, listen, like, no, you're taking this forever. This is not like a only take it during, the spring months, or only take it sometimes. Like, no, Long Beach is the dirtiest area in the United States in terms of air pollution. State of the Air report came out last week. Shout out American Lung Association. So that is something that is, significantly impacting these communities is that.
You said when you realize where someone comes from, you kind of lean into really making sure that you can assure the best outcomes. And so there are different terms we use for that. One basic term that people may be familiar with is triage. And triage is basically sorting. And this is what we expect physicians to do, is to sort out their patients according to level of need. Because we don't have infinite time, we don't have infinite resources. So we should focus our most kind of important resources for those who have the greatest needs. But this is one of the challenges that is often lacking in medicine, is that risk sorting, that risk stratification, to say, hey, this is the patient, they need to see the specialist, they need a biologic, or just, whatever it is. And, these are one of the problems that, we're working to solve.
And since we're here and we're we talked about kind of diagnosing asthma, which is clinical diagnosis, wheezing, coughing, shortness of breath, but also a little bit of a objective diagnosis, getting, obstruction on pulmonary function tests, where you take a deep breath in, you blow that air out. We see airway obstruction on this test. Then we have to treat them. Now, Dr. Okelo was so gracious to bring a bag of potential therapies. So I want to bring that bag out, and I want to go over what's in the bag of therapies for pediatric asthma.
Absolutely. And before we jump into that, we have touched on diagnosis, but I think for your audience, I think it'd be helpful to go through the criteria, and I'm going to go through what I call the lay criteria, the regular person's understandable criteria. Now, what's in the NIH guidelines, right? Because we got to speak regular language. I share with my patients that the first criterion I look at is, are there repeated episodes of asthma-like symptoms? Coughing, wheezing, chest tightness, chest pain. So in kids, chest pain is almost universally asthma. Decreased stamina, shortness of breath, or any one of those happening in a repeated pattern. Not just once, but 2, 3, 4, 5 times. Not an official part of that criterion, but we know these symptoms occur under very kind of consistent or classic situations or conditions. Number one on the list are viral respiratory illnesses. Another common one is exercise. We've talked about exercise. And then for whatever reason, the nighttime seems to be an issue, right? There's no noontime asthma attacks. They're 10, 11, 2 p.m. or 2 a.m. So again, are there repeated episodes of asthma-like symptoms that occur under classic conditions? And then second is, do the symptoms improve with asthma treatment? So we've already alluded to patients being given asthma medicines for a different diagnosis. But if those asthma medicines, your albuterol, your prednisone, whatever they give you, improves your symptoms, then that would be consistent with asthma. Those medicines are very specific. They're intended to help people with asthma. There's a caveat to that, and I say that that treatment needs to be what I'd call an adequate trial of therapy. Okay, so it needs to be the right medicine, taken the right way for a long enough period of time for us to be confident about whether it works or doesn't work. It doesn't have to work, but as a physician, I want to be confident that we've given it a good shot.
What's a good shot? What's the amount of time?
If we're talking about the anti-inflammatories that you mentioned earlier, like the inhaled steroids, it should be at least a month of daily use to be fully confident. And again, there's a consideration for how much is being used. There's a lot of undertreatment, as we know. If it's the oral steroids such as prednisone or prednisolone, in pediatrics, at least 1 milligram per 2 pounds of body weight. It's kind of a little calculation, obviously, that we go through. So that's just some other considerations. And then third is just making sure there's no other explanation other than the asthma. So those are the criteria that I go through with patients. And like I said, I try and relate it in understandable language.
So Sande, show us.
This is a model that I've found incredibly useful. And in general, I find visual aids helpful to patients. Otherwise, they're just listening to me ramble on and on. But this is a healthy kind of, picture's worth 1,000 words. And so I've two types of airways here. The first airway is the inflamed airway that you referred to, kind of swelling of the airway lining and overproduction of mucus. And if we compare that to the non-asthmatic airway, we can see that this inflammation narrows the passageways, which is what you were talking about. And really that narrowing is what translates to symptoms. And so we have to think about the right medicines to reduce or eliminate this inflammation, as you know and have talked about already.
Remember, you guys, the kid's airway is already narrower than an adult airway. So you're dealing with an airway that's already tighter in diameter. And so now if you put asthma on top of that airway, their symptoms are going to be probably more severe. They may not say anything because they're kids, but that's the worry here.
The other component, which we touch on, which I think people are far more familiar with, is this muscle that surrounds the airway that can tighten or contract, what we call bronchospasm. And this is what everyone's rescue inhaler works on. So people often live and use their rescue inhaler all the time, probably too much, which works on this muscle but does nothing about the inflammation. And as we know, when you're in that situation where you're relying on just relaxing this muscle instead of treating the inflammation, you will still get into trouble.
And that's another important point to think about is when you look at albuterol, short-acting beta agonist, these individuals that rely on just albuterol during an asthma attack, right? When somebody's having wheezing, when somebody's having coughing, shortness of breath acutely, the more you use albuterol, actually, the higher your mortality, the higher your morbidity, because albuterol does not address the foundation of what your problem is, which is the inflammation. It only addresses the bronchoconstriction, but you're being bronchoconstricted secondary to the presence of white blood cells in that area that are causing that muscle that Dr. Okelo just described to contract, to start tripping. And that's the problem when you're not seeing appropriate specialists, or when you're not truly understanding what your illness is you're continuing to use albuterol to treat inflammation, and it does not, absolutely does not do that. In fact, so much so it does not do that, that the global strategy for managing asthma has actually changed in the last 8 months. The global strategy now says anytime you take albuterol, that short-acting rescue inhaler, you need to take an inhaled corticosteroid. And that's not only in adults, but it's also in kids.
Absolutely.
Right?
Absolutely. If you find that your albuterol, your rescue inhaler is not working, it's because of what Dr. Rutland just said. You're not treating any inflammation at all, and it's rendering your inhaler useless.
You got some other toys on the table.
I do. Earlier, we talked about an adequate trial of therapy, so taking medicine the right way. And there are a few devices that are helpful or important in that. The first for any type of inhaler is to use a chamber that we refer to as a spacer. Whether you're 6 months of age, a teenager, a young adult, an elderly, a senior, these spacers are critical in maximizing the delivery of the medicine to the target, which is the lungs, but also in terms of avoiding side effects. Patients always ask about side effects. What's a side effect? And that's appropriate. Well, these help limit some of those side effects, whether it's from your rescue inhaler, such as getting a rapid heart rate, or your inhaled steroids, such as getting thrush. These are helpful for that.
Do you recommend that for all of your patients? Using a spacer,
Absolutely.
no matter their age?
Absolutely. And so there are spacers. I held up a spacer with a mask, which typically we use in children who are under 5 years of age, mostly because when we give the inhaler, we just let them breathe in and out with the mask in place on their face. They're a little bit too young developmentally to coordinate what we do with the other spacer, which is to take a slow, deep breath and hold it for 5 seconds. So the child has to be developmentally able to follow those directions. And so even for some older children, if they're not able to, we'll use the spacer with a mask. But yes, every child of any age gets a spacer. And like I said, the younger children will get a mask.
And then you have is that a nebulizer?
Yes.
It is really not cool to carry around a spacer, doctor. So I'm assuming you're teaching your teenagers or adults how to use the inhaler by itself. I thought it was interesting that you said they might have more side effects. I feel like that might be motivating to use the spacer if I haven't heard that before.
Absolutely. Thank you for bringing that up. Yes, in terms of kind of total care, which is what you're talking about, is recognizing what the barriers may be to the patient or the family following the treatment plan. And it is actually very important to recognize that peer pressure among our teenage patients in particular is a factor, and absolutely using a spacer in public is not cool at all. I think there are two solutions around that. One is if they are taking their daily anti-inflammatory, that can be done in the privacy of their home. So ideally, that's an incentive for them to take the anti-inflammatory so that they don't have to use the spacer with the rescue inhaler in public. So that's one. But second is in 2025, there are so many different asthma medicines that are out there. There are asthma rescue inhalers where you don't need a spacer. So it helps the provider to be creative in recognizing, well, how do we best put this patient in a position to succeed and follow the treatment plan?
Can I see that spacer? One of the things I've always thought, and again, can you imagine if this spacer was a Supreme spacer, or this spacer was a Nike spacer, or this spacer was a Louis Vuitton spacer? Like, I always felt like big brands like that could get in on this, and that would incentivize these high school kids to use their medications because it's cool. Like, I mean,
Genius.
that's what I would do.
Yeah.
Like, if I were Nike, if I just put a swoosh on this thing, maybe made it white, I mean, just making it look cool, then all your friends that have asthma are like, I want that spacer. And then they look cool. Like, that's the marketing campaign that I would employ.
I think that's an excellent point, and I would take it a step further. I think that there's an opportunity for any one of these companies to identify prominent athletes to start with who have asthma. The number of athletes who have asthma is much higher than people realize. I think over the past few years, we've had to learn, unfortunately, about some famous athletes who've died from asthma. Recently, Ricky Henderson being kind of the most recent, who suffered for a long time from asthma. And, again, just to highlight the importance of this podcast, asthma is such a totally treatable condition. No one should ever suffer from it, let alone die from it. It's really, honestly, inexcusable. So there is a great opportunity for famous people with asthma to be identified, hopefully, and encourage and make it cool to use a spacer for greater good.
The 100-meter gold medal
Yes.
winner from the United
Noah
States,
Lyles.
Noah Lyles, had an asthma attack right afterwards. I mean, can you imagine lifting this up? Nike swoosh, like, get out of here.
Absolutely.
Like, what is that? What are we missing here?
Yeah.
Yeah.
And if you guys need help designing it, we're all here to help you.
We are.
We'll just take a small percentage.
Totally. To round out the discussion that we're talking about, you mentioned a nebulizer, which most families with children with asthma are well acquainted with. This is a machine that creates a mist out of the medicine, and the child breathes it in. There are really two ideal ways that's done. I have one example here, and that's what we refer to as a mouthpiece. Any child, typically 5 years of age and above, should be able to use this mouthpiece. There's some tubing that connects from the machine to here. The medicine is placed in what we call a cup, and then the child holds the device in their mouth for the full duration of their breathing treatment. If they're too young, say they're a toddler or an infant, then there is a face mask that can be attached here that's held into place with some straps. Those are the two ways to utilize this nebulizer to optimize delivery of the medicine to the lungs. Some parents will just take the tubing and hold it by the child's face, what we refer to as blow-by, which is totally inadequate. So again, we talked about an adequate trial of therapy, the right medicine taken the right way. So we're talking about how to take the medicine the right way here.
So again, when you look at the general management of asthma, pediatric asthma even, you're going to use an inhaled corticosteroid daily, at least. Your rescue therapy, you want to be albuterol with an inhaled corticosteroid when they take their albuterol. And then you're going to up titrate the dose of inhaled corticosteroid. You might add other controller medicines like a leukotriene receptor antagonist. And then you might add, a long-acting muscarinic antagonist in some cases. If patients continue to exacerbate, I'd be remiss if we didn't mention, because of the immunology of asthma, which we understand, right? We understand the messaging molecules that are involved in recruiting the white blood cells into the airway. We call these molecules cytokines. We can use certain products. You kind of mentioned it earlier. You said biologics. What are biologics? What did you mean?
First I'd add what you've just highlighted very quickly is that there are a full complement of medicines out there to manage asthma. Again, there's no reason for any patient to be suffering from asthma. The kind of newest on the scene, although one of them's been out for 20 years, the others have come online in the last 10 years or so, are these injectable anti-inflammatory asthma medicines that may be given anywhere from every 2 to 4 weeks. And they are intended for the patients who have gone through the other complement of medicines that you ran through, but yet are still suffering from asthma attacks, requiring prednisone or going to the emergency room and so on. As you know, this class of medicines that we call biologics have been a total game changer for those patients on the severe end of the spectrum, and really have been life-changing. And it's hard to imagine kind of managing patients without this class of medicines.
Obviously, Dr. Okelo is at UCLA. Obviously, Dr. Livingston is at Miller Children's. I find my way to stay in touch. But for individuals that are out there in community practice and not as in touch as we are, what advice would you give them to sort of stay up to date, at least with asthma management?
Pediatricians have a conference every year. The American Academy of Pediatrics has a conference. It really is one of the best ways to stay up to date on changes. And there are, American Academy of Pediatrics newsletters. So we get updates on every subject imaginable. You have to make the time to look at those things, but a once-a-year conference, I think, is an easy way to consume a lot of information in a short period of time.
Thinking about creative strategies to help physicians help themselves. So one example I'm thinking of is actually on the table. We've got a little poster that says respiratory treatments. And this is a great way on keeping up to date with the treatments that are out there. It is a great way to have a discussion with patients about medicines they've used or medicines that I would like them to use. So, one example of a tool that can help physicians help themselves, navigate those asthma waters, if you will, with patients.
So we're going to do a little parent pop quiz because, again, we're all parents. I know a lot of you out there are parents, and at least from my experience, and they have said the same thing. A lot of the times we're spending time with parents who have anxiety because their children are sick. So we're going to go through some questions here, and I just want you guys to answer what comes to mind. This is one of the questions that we received. My kid has a lingering cough after a cold. Is that asthma acting up?
Yes. No, parents like definitive answers, I have to say. Like, if you're wishy-washy, then they don't know what to do, but it's obviously not a black and white answer. I would say there's a good chance if your lingering cough is lasting more than 3 weeks, then you could have a component of reactive airways and asthma, but in children, sometimes kids can literally cough the entire year from back-to-back viruses, and they don't always have asthma, so that's the nuance, I think.
Obviously, I see a select portion of the population, so it's common that I see kids who've been coughing 6, 9, 12 months. Part of that pattern can be the viral illness setting off the cough and it lasting 2, 3, 4 weeks. I would say in my experience that many of these kids do respond well to asthma treatment. They often meet the criteria that we discussed earlier in terms of diagnosis. But Dr. Livingston and I see slightly different, facets of the population.
Doc, do we really have to use the inhaler every day if my kid feels fine?
Yeah.
Yes.
Yes.
Absolutely. I think for a lot of patients, when they go to the doctor's office, our minds are like a black box. And so understanding the inflammation, I think, does help circumvent that question a little bit. Like, well, my kid feels fine. Well, I tell them that inflammation is there all the time.
Yeah.
And then under those conditions, it intensifies. So if it's there, then we got to use it.
I mean, by that same token, here's another question. How do I know if my child's asthma is well controlled?
They're not coughing at all unless they get sick, but even then, I would say any cough, is not controlled, and they're sleeping well without any interference. They're doing their physical activities without any interference from a respiratory standpoint, of course. I would call that well controlled. I guess there's an objective part of this too that I don't measure in my office as a general pediatrician. Is there still obstruction? That's not always something I can see.
I would add on a few other considerations. First is I've already referenced an asthma questionnaire. The one I happen to use is the Pediatric Asthma Control and Communication Instrument, but there are others out there such as the Asthma Control Test. These ask relevant questions about your child's asthma and help determine if your child's asthma is controlled or not. So I think that's one readily available tool. They're online. Parents could actually go find them and fill them out, and it tells you right there. Second, which you alluded to, if you see myself or Dr. Rutland, there are breathing tests that we can do that we factor in to help determine if your child's asthma is controlled. And in fact, there are two tests that we utilize in our office. One we've referenced already, and that's what we call spirometry, which measures your lung volumes or lung capacity, as we say. And then the other test measures inflammation, and that is called fractional exhaled nitric oxide. So we put all these tools together to help determine if your child's asthma is well controlled. But there are ways for parents to come to that understanding that are simpler, and I think the questionnaire is one very easy way to do that.
Should we skip practice if it's windy or smoky outside?
I usually defer to the parents because they know their child best. And if I'm seeing a child in front of me who is using their inhalers and they're not having trouble breathing, I tell them if they're old enough, you have to listen to your body. If you go out there and you're not even playing yet and it feels a little bit tight in your chest, or you feel like you have to use your inhaler very frequently, maybe that's not a good day to be there. But I think it's so variable. I would say, yes, you can try playing if you feel okay right now. But if you are barely able to participate, then you should be stopping.
In this area, particularly the part of LA that I'm in, people have become much more tuned to looking at the AQI, the index. Really on the heels of the LA wildfires, people kind of became aware of that. And so I encourage patients to kind of follow that as well. And, on poor air quality days, at least to be more cautious, definitely have their inhalers available.
And I'm the same way. I mean, one of the things I do tell my patients, and again, I'm a little bit of a nerd, and I'm like, listen, when it's smoky outside, and we have to deal with wildfires down here in Southern California, which happen all the time. When there's an active wildfire going on and there is smoke in the air, the smoke inhalation can cause the same type of inflammation that's present in 84% of asthmatics, which is this type 2 inflammation. And so for me, if you're asthmatic and there's a wildfire going on and it's within a 20 to 30-mile radius of where you are going to have that practice, I am more inclined to say, like, listen, I don't think it's a great idea for your coach to be having practice in youth sports. You're not getting paid $30 million to go out there. Like, if you were, like, then I understand the risks involved. But like, when you're 8 years old, 9 years old, and we're talking about baseball practice on a Thursday, like, nah, bro. Like, you probably can hold off on that. Because I remember during the wildfires this year, my God, like, I got all my friends in LA. I had to talk to so many different, like, district whatever coaches and managers or whatever, and I was just like, listen, like, why are you having practice, man? This home's still burning down. Like, is it that serious,
Totally.
So I do think that common sense is important.
Absolutely,
Yeah.
absolutely. I'd like to make a small plug. There's a project that I'm working on where we factored in kind of the AQI to predict asthma attacks. And if people are interested, they could go to breathium.io and download that. It's for the LA area. It's specific to LA.
Actually, and I do use that, and I did use that week. But yes, it's this is something I think is important. I think this is something that needs to literally be in our back pocket more often as parents taking care of our children with asthma, is truly understanding how the environment impacts the degree of airway inflammation, because people often take advantage of the fact that the lung is a really great organ because it does its job well, but it's also a really sensitive one because it's constantly exposed to the environment and it manipulates the way that your immune system can respond to things. So I think that's important, is taking into account the environment and how it impacts you. What are 3 tips, and this I want these from both of you guys, that you can give parents to help those parents manage their kids with asthma? My kid has asthma, so I'm going to listen.
Number one, if your child has a cold, particularly with a cough, start using your inhaler, whatever their inhaler is. So for some kids, it's intermittent asthma. For some kids, it's their steroid plus long-acting beta agonist, whatever your inhalers are and your medicines for when you flare up. Start using them immediately. Don't wait until your child is having trouble breathing. Number one. Number two, think about the environment. So we go back to what are the triggers a lot, and whether it's allergens in the home, do you need a air purifier for your child's bedroom? That can make a huge difference if they have dust allergy or if you have pet dander or whatever their other triggers are, if it's outdoor allergens, changes in weather. Like, pay attention to those things and try to get ahead of it, again, rather than after the fact dealing with the problem that it causes. And then I think call your doctor and have ideally a doctor, whether it's a pediatrician or nurse practitioner or family practice physician or your pulmonologist, somebody that you can talk to regularly about this issue that knows your kid, so that if any questions come up, rely on that person to help you if it's not going the way it's supposed to, rather than going to urgent care to people that don't know your child or just throwing Robitussin at it for 2 weeks, which we all know doesn't end well.
I would say, in addition to that, first, there may be members of the audience whose child has been diagnosed with reactive airway disease. I think the first thing would be to really nail down your physician. Is this really what we're talking about is asthma? So let's name it in a way that's understandable by parents, by children, by healthcare providers. So I'd say that first. Second is if that diagnosis of asthma is confirmed, see your doctor regularly. At a minimum, it should be twice a year, but probably more times quarterly, so 4 times a year, just for an asthma checkup, even if you feel like your kid is doing great. Well, they have well child examinations, right? We can have well asthma visits as well. And that helps you stay on top of just little things that may come up. The child may not be taking the inhaler the right way. They may actually be out of medicine and not realize it. They need refills. You may, it's a chance to inform your physician about flare-ups that have happened. You had to go to urgent care. You had to go to the ER. You had to end up on prednisone. Your doctor has no way of realizing that unless you have regular check-ins. And then the third thing, again, I've been a proponent of this. Hey, fill out your asthma survey. Those do that quarterly as well. That's another check-in to make sure things are going well. And those are the 3 tips that I would offer.
I mean, I appreciate those tips. I think that those tips are extremely important coming from both of you. I really appreciate you guys being here. I think, for me, those 3 tips you guys left us are the key takeaways from today's episode. Is there anything else that you want to say that you want the audience to know?
You know your child best. And I think parents are pretty good at trusting their gut instinct when they know that there's something going on with their kid. They don't always feel confident about bringing them to us, to their pediatricians. They feel like they're wasting our time, which they never are. They second guess themselves. I think parents need to trust themselves more and don't be afraid to ask, is this normal? Is there something we can do? And advocate for your child because we don't know them as well. We see them for a very short period of time. So we need to know everything that parents are seeing.
Yeah, to piggyback on that, I think until your child's asthma is under good control and can do anything and everything, without the worry or concern of having an asthma attack at any moment, to keep pushing, it's not easy. But you are your child's best advocate. Be persistent. And, in some circumstances, unfortunately, if you're not really getting the answers that you want, then you need to change directions.
Typically speaking, when we finish off an episode, we always like to leave with a positive pulse. It's kind of a positive patient experience that made you feel good.
This now young lady, I think she's a junior at UC San Diego. Honestly, the family had kind of been all over. They'd been to Center in Northern California. They'd been to the East Coast. And basically, when I met this child, she was on daily prednisone. This is an active soccer player, so an athlete who really just was being debilitated by, undertreated asthma. We ultimately got her on a biologic, and she just soared totally after that. Was able to compete in soccer without any issues, no restrictions. The family could travel. I mean, it just, as Dr. Rutland knows and Dr. Livingston, these medicines, can be total game changers. And like I said, I still stay in touch with the family because, patients don't realize this, but we do think about them.
Yeah.
So
where can we find both of you?
I am here local in Long Beach. My private practice is Pediatric Medical Center. It's been established since 1930, and we pride ourselves on being old-fashioned pediatricians, being on call. I'm always available to my patients and friends who call and text, and everybody. You're always on call as a doctor these days, but that is where I am the vast majority of the time when I'm not with my children, driving them around. And we have a website and social media, and we try to educate families
What's
that
your
way
website and social media?
pediatricmedicalcenterlb.com, and same Pediatric Medical Center Long Beach for our social media pages. Should be easy to find.
yeah, I'm currently at UCLA. So if you Google UCLA Pediatric Pulmonology, I will pop up. You can reach me that way. You can also check out breathium.io as an additional resource to reach me and some of the resources we talked about as well.
Listen, you guys, thanks for listening and watching at The Health Exchange. You can find us on Instagram at The Health Exchange Podcast. You can find us on YouTube, Apple Podcasts, iHeart, Spotify, wherever you get your podcasts. We come out every Thursday morning at 6 a.m. Pacific, 9 a.m. Eastern. Really appreciate you guys being here today. Thanks again to our guests. We'll see you next time.